I would like to welcome Tristan to get started on her piece, and we appreciate very much her expertise as a genetic counselor at Sick Kids Hospital in Toronto.
Thank you so much, Genevieve. And just bear with me a second, everyone, while I just share my screen. Okay, can you see that okay? Or is it showing my slides or like the presenter view? Good, perfect, okay. So before I begin, I just want to take a second to introduce myself and also say thank you so much for joining me today on a very special day as it is Genetic Counselor Awareness Day. To learn more about the genetics of retinoblastoma, as Genevieve mentioned, my name's Tristan Charlinski, and I'm a research and clinical genetic counselor at Sick Kids. I currently work with the Sick Kids Cancer Sequencing Program, or KICS, as well as the Pediatric Cancer Genetics Clinic. And my role is really to provide genetics education, psychosocial support, and counseling to families of children with many different types of cancers. But this includes working with patients with retinoblastoma, as well as their families and the Sick Kids RB team. And so before we talk about RB specifically, I just wanted to cover some genetics basics to help set the foundation. I'm sure many of you have heard before that our bodies are made up of many, many cells, and inside of our cells, we have our genetic information, or our DNA. Our DNA is packaged into structures that we call chromosomes, but if we were to unpack our DNA into its simplest form, we can really think of it like a long strand of four different letters: A's, T's, G's, and C's. And within this long strand of letters, there are important regions called genes. We have two copies of every gene, one that we get from the egg and one that we get from the sperm. And the DNA letters within the gene provide instructions for the cell to go ahead and make proteins. Proteins have different jobs throughout the body, but ultimately they help to control our growth and our development and help keep things healthy. And so moving on to talk a little bit more about retinoblastoma specifically. I'm sure
And
many.
I'm sorry to interrupt you.
Yeah.
We're not seeing your slides in the way that you would want them. We're
Oh,
seeing all of your slides along the bottom.
oh, okay. Like with my notes?
Yes,
How about now?
there we go.
Oh,
Thank
okay,
you.
perfect. Thank you. Perfect. So as many of you know, retinoblastoma is a childhood cancer of the retina. This is the part of the eye that responds to light. RB is the most common childhood eye cancer, and it occurs in about 1 out of 15,000 births, and typically occurs in individuals before the age of 5 years. As many of you know, RB can be unilateral, meaning only affecting one eye, or bilateral, meaning it affects both eyes. It can also be what we call unifocal, meaning there's only one tumor present, or multifocal, meaning there's many. And something that's important to note is that most people who have retinoblastoma have no family history of retinoblastoma, which sometimes we can see when patients come to clinic and are diagnosed with hereditary retinoblastoma, can be quite a surprise, because when we expect things to be genetic, I think a lot of times we expect there to be a family history. And something we'll talk a little bit more about in detail is, why sometimes these things occur without there being a clear family history known. So to better understand the genetics of retinoblastoma, we first need to explore the specific gene that's related to the condition, and this gene is called RB1. RB1 provides instructions for a protein that's very cleverly and uniquely named the retinoblastoma protein, or PRB. And this protein falls into a category of proteins that are called tumor suppressors. And really, what this means is that the RB1 gene provides instructions for a protein whose job is to help control how fast a cell is growing and dividing. We know that this is an important job for this protein to have because cells that start to grow and divide too fast can become cancerous. And when the cells of the retina grow and divide too fast, that becomes a retinoblastoma or can become a retinoblastoma. And so when someone has a harmful genetic spelling change in the RB1 gene, this can cause the gene to not work properly and increase a person's risk or chances to develop retinoblastoma. The scientific term for a harmful genetic spelling change, which some of you might have seen before on a genetic testing report, is a pathogenic variant, or sometimes referred to as a likely pathogenic variant. And in this diagram below, we can see here that if we zoom into the letters of the RB1 gene in this specific person, we would expect to see the top bands of letters in their DNA. So we'd expect to see a GC pair at this location in the RB1 gene. But we see below that when we actually take a deeper look into the DNA letters, this person has a TA pair instead of that GC pair. And the result of this harmful change is that when the machinery of the cell that makes the protein, which is shown in blue here, goes to read the DNA, it gets to this A letter when it should normally be a C, and it doesn't recognize it. And because the instructions are changed and this protein can no longer read and recognize it to make the retinoblastoma protein, it stops working, and it doesn't produce any protein at all. And everybody's genetic spelling change can be different. This is just one example of one type of genetic spelling change. And so this is what we call a substitution, where one letter is swapped with another. Sometimes people can have letters deleted or letters added, and there can be different impacts on the protein. So everybody is also unique who has retinoblastoma, and the genetic counseling that comes with that can also be very specific and unique, depending on what DNA changes are found in an individual. And so how does all of this increase someone's risk to develop retinoblastoma in their lifetime? Well, we know that all cases of retinoblastoma are genetic, meaning that they're caused by genetic changes that impact the RB1 gene. But the difference is really about when and where the harmful genetic changes occur. So there's two distinct categories that we can think about. The first is sporadic RB, where the retinoblastoma occurs by chance. And as we go through life, we all acquire random harmful DNA changes to our cells. The impact of these changes really depends on which cells have the change and which genes those harmful changes occur in. But someone can develop sporadic harmful changes in their retinoblastoma gene. And so in sporadic RB, someone goes through life and they acquire a harmful DNA change in their first copy of their RB1 gene, because remember, we all have two copies of the gene, in one single cell in their body. And we see here that in this case, where only one copy is working and the other has a harmful DNA change, this person doesn't develop a retinoblastoma yet because that second copy of the gene is still making that retinoblastoma protein, and it is still working as a backup essentially. As that person continues to go through their life, they have to then develop a second harmful DNA change in that exact same cell out of the many, many cells of their body in the other copy of the RB1 gene, when we have 20,000 genes in our DNA, to then cause in that single cell no RB protein made, and therefore a retinoblastoma develops. And so you can see with sporadic RB, this takes many steps, and it's really a game of probability. It's by chance. It's something that, unfortunately, we have no control over, and it just happens. The other category is hereditary retinoblastoma. In this scenario, someone is born with a harmful genetic change in one copy of their RB1 gene. What this means is that that DNA change exists in every single cell in their body. Therefore, when this person goes through life, all they need to acquire is one harmful DNA change in their other working copy of the RB1 gene in a cell to then cause that cell to not have any of the working protein and potentially lead to the development of a retinoblastoma. And so you can see with these two scenarios overlapped on top of each other that sporadic RB takes many more steps, whereas hereditary RB, an individual already starts out with one copy not working. And so it takes less time to potentially develop that second random harmful DNA change in the second copy of the RB1 gene, which then causes the retinoblastoma. And so to summarize with that very, very kind of complex topic, all that to say that sporadic retinoblastoma has what we call somatic variants or harmful DNA changes that occur in the DNA of the retinoblastoma or the tumor cells only. And these harmful DNA changes are not present within someone's sperm or egg cells and therefore are not passed on to the next generation. Whereas hereditary retinoblastoma is caused by what we call germline variants, which occur in all cells of the body, including our sperm and eggs, and they can be passed down to our children or to future generations. And so tonight we're going to specifically focus on the rest of the talk on hereditary retinoblastoma and the genetics of it, because within hereditary retinoblastoma, the genetics itself can be quite complex. So we know 40% of retinoblastoma is bilateral and 60% of cases are unilateral. When a child is diagnosed with bilateral retinoblastoma, we know that it is 100% of the time hereditary. And we say that it is hereditary even when a person has genetic testing, but they have negative genetic test results. And so we don't find one of those germline harmful DNA changes that they were born with. And this could be because maybe our technology isn't up to detecting some very sensitive types of DNA changes, and we don't know about that. And so potentially a negative result doesn't 100% rule out the chance that it is not genetic or hereditary. And because we know that if someone develops tumors in both eyes, the chances of that happening in a young child randomly by chance to develop all of those harmful changes in the RB1 genes separately in those cells is very unlikely. And so the kind of more probable scenario is that there is a harmful DNA change that maybe we're just not finding. Moving now to talk about the other part of the pie graph, unilateral RB. So as I mentioned, 60% of cases are unilateral. And within those 60% of cases, when a child is diagnosed with unilateral retinoblastoma, we know that 85% of the time, that is sporadic retinoblastoma that occurs by chance. And 15% of the time, we'd say that that is there's a 15% chance that that is hereditary retinoblastoma or caused by one of those germline harmful genetic changes. Now, this is kind of the most basic explanation, but as I mentioned earlier, everybody is unique. And so when we see individuals come to clinic, there can be many factors that kind of change these numbers for the person. As I mentioned before, typically, there isn't a family history with hereditary retinoblastoma. However, when we do see someone who has a diagnosis of retinoblastoma and there is a family history, even if it is a unilateral retinoblastoma diagnosis, that changes these numbers. Additionally, when someone has a unilateral retinoblastoma diagnosis, but it's a multifocal disease, meaning that there's multiple tumors in the eye, that can also change these risk numbers as well. So it's very complex, and it really depends on the individual and their family history, as well as other information. And so with hereditary retinoblastoma, we know that there's a risk for secondary tumors, and these tumor risks can change based on age. Um, for individuals who have these germline RB1 pathogenic or harmful genetic changes, we know that the chance to develop a second tumor is about 20 to 25% to the age of 50. And because we know that there's an increased risk for these individuals, we have screening guidelines for surveillance to help make sure we can stay as healthy as possible. And so we know that unfortunately we cannot prevent a cancer from happening at this time. One day, that is the hope in the future. But with surveillance, our goal is to detect cancers and tumors as early as possible, because we know that if we detect them early and treat them earlier, the outcomes tend to be better. And so, for individuals who have genetic testing, or based on their kind of disease status of bilateral retinoblastoma, and are confirmed to have hereditary retinoblastoma, there's surveillance that occurs through multiple exams under anesthesia, as well as genetic testing for family members for that same variant to help determine who else might be at risk to develop retinoblastoma in their lifetimes. And then additionally, for individuals who are determined to have sporadic retinoblastoma, they are followed by clinical exam, and there's not any further genetic workup for family members, because we know that if we don't identify a harmful change in them, then there isn't anything targeted to test their family members for. And so, as I promised, I know this is a very busy slide, but going back to the reason why individuals with hereditary retinoblastoma typically don't have any family history. And so the reason for that is because most cases of hereditary retinoblastoma are what we call de novo. This is where a spontaneous new genetic change occurs when the child is conceived. And so a random genetic change occurs by chance in the single sperm or the single egg that made the child. And therefore, the child has a RB1 harmful genetic change in every single cell in their body, but neither of the parents test positive for that same genetic change. On the other hand, sometimes the DNA change can be inherited from a parent, and this can be seen in around 5% of cases of hereditary retinoblastoma, where either mom or dad could have the RB1 genetic change, and there's a 50% chance that they pass on the working copy of their RB1 gene to the child, and a 50% chance that they pass on the non-working copy of the RB1 gene to their child. And I just want to take a moment here to just really stress that whether hereditary retinoblastoma is de novo or inherited, there's nothing that we can do or nothing that we cannot do in pregnancy or before or after that causes these harmful DNA changes to happen or prevents them from happening. It's really something that happens by chance, and nothing we have control over. Even if we ourselves have a RB1 genetic change, we don't choose which copy of the RB1 gene we pass on to our children. It's something that happens by chance. And I know from the families that I work with in genetics that if we had the choice, we probably wouldn't do that. We wouldn't want to, you know, um, I guess what I'm trying to say is that, you know, it's not something that we control. And I think just something that comes up a lot when especially we find out that this is inherited, is feelings of guilt. And I just wanted to say and take a moment to say that that is something that is very normal to feel and very valid, but that we're not responsible for passing on harmful genetic variants to our children. It's not something we choose. Okay, and then just the last thing I want to touch on is just the inheritance pattern. So we know that when an individual has a pathogenic or harmful RB1 genetic change, even if it's de novo, so new in them for the first time, they could pass that on to their children. And so when someone has one of these pathogenic variants, as I mentioned, there's a 50% chance of passing on the working copy of the gene and a 50% chance of passing on the non-working copy of the gene and having a child who is at increased risk for hereditary retinoblastoma. And I also want to take a second to stress here that this probability is independent. So this means that that chance is for each pregnancy. So meaning that if someone has two children, we'd expect, statistically speaking, that one child would inherit the change and one child wouldn't, but that's not always what we see in clinic. And so it's really like thinking about like flipping a coin each time independently. You could flip a coin 5 times and get tails 5 times. It's the same with autosomal dominant inheritance. So even though the chances are 50-50, you could potentially have 5 pregnancies where every pregnancy inherited the RB1 pathogenic variant, or 5 pregnancies where none of them inherited the RB1 pathogenic variant. And again, I just want to stress again that that's not something that we have control over. And that concludes my review of RB genetics. I want to say again, thank you so much for joining, and I'm happy to answer any questions at this time.
Thank you so much. Very, very informative. Some terms and ideas that are definitely new to me. And I've been hearing this explanation for 35-ish plus years. So thank you very much for giving it to us in very layman's terms and understandable ways. And I hope that you all feel the same, that I've really grasped some of the concepts in a different way tonight. So I really appreciate that. It was very understandable for those of us that don't have a science background. It can sometimes be overwhelming in terms of the jargon and the content, but you did a really great job explaining it for us. So thank you so much.
Thanks, Genevieve. I really appreciate that feedback, and that's really the goal. And really, the main part of my job is to try and explain very, very complex. Sometimes these results are even complex for me to understand, and it takes a minute to go through and make sense of it. And so I'm glad to hear that it was presented in a way that was easy to understand, because I can appreciate how complex and nuanced and detailed these things are.
Absolutely. And the genetics are just one piece of the puzzle in all of the RB things that we have to discuss. So thank you so much for the work that you do. It's very important to all of us. So I would love to, let you guys think for a moment about what questions you might have. I have a short poll that I wanted to put into the chat, which I currently just, there it is. And it is just asking the group where you heard about the event, maybe where you're from, and what is your relationship to the retinoblastoma community. So I've just put the link in the chat. It's a Google Doc, just a quick couple of questions while you think on what questions you might have for Tristan. Feel free to use the hand raised, as I see Marg has got her hand up first. So please, when you're ready.
Hi, thank you. I'm not sure if you have the answer to this, but I'm wondering, is there a place where we can go to get an accurate list of secondary cancer risks? specific cancers that tend to be a higher risk?
Yeah, I can recommend, I will like caution that this is a very scientific resource, but one that genetic counselors commonly use and I use very frequently in my practice. It's called Gene Reviews, and I'll actually just paste the specific RB1 gene. It's a very comprehensive resource, so it talks a lot about genetic testing and goes through a lot of the counseling information that I presented tonight. Maybe in more scientific terms, but there is tables that will be present on that website that will list kind of those secondary cancer and tumor risks. And
Okay.
that site is like well updated, as well as the scientific community and the retinoblastoma research progresses, and we learn more about hereditary retinoblastoma as well.
Okay, thank you. You said you're going to put a link in there or at some point.
Perfect. We appreciate that. And I will also put Tristan's email address into the chat so that, as I mentioned, if anyone doesn't get their question answered this evening, then you're welcome to follow up with her. Or if you think of something later or in the coming days, then she's graciously allowed us to reach out to her afterwards. Do we have any other questions from the group? Jennifer, I see you have your.
Yeah, more of a comment. I just want to really say thank you for saying that that it's not the parents' fault, because that's something that my mom always blamed herself and had a huge amount of guilt. And it's funny, I'm basically your case study. So I'm a twin and only one of us got RB, and I'm also one of five. So out of five, I'm the only one as well. But yeah, I know that's huge for parents to have that support. I'm actually going to show my mom this, just to hear it from a genetic counselor, not just from me, that it's not her fault. So thank you so much for saying that.
No problem. And I think that's something just super important to reiterate. And I think sometimes too, we see patients and families who feel maybe like they're alone in that feeling. And it's not just limited to retinoblastoma. It's something that's common across all genetic conditions. And it's a very normal feeling, and completely valid. And I think talking about it helps too, to kind of help work through those feelings. But it also helps to hear from a healthcare professional and an expert in genetics, and kind of just reinforce that too, because I think a lot of the times parents and families know deep down that it's not something that is their fault, but intrinsically we just like can't help but go to that place in our heads.
Definitely. Thank you for that. I know that's something that my mom also mentioned frequently, whether or not she did something wrong in pregnancy. I'm a unilateral sporadic case, as I learned in your discussion, because neither of my parents are carriers. And yeah, it's completely new mutation. And I have two unaffected children myself. So it started and ended with me and my family tree, and that's it. So we're grateful for that explanation. Okay, is it Kirsty?
I think you're muted.
Sorry, yeah.
Okay, are we good? Well, my name is Kirsty. It's like putting church and thirsty together. My son is 8, and I think we have just coasted a lot on just getting healthy, and then family life has taken over. And I'm starting to wonder how to present to him in a way that won't cause anxiety about the RB1 gene. Because I know he'll have to take over his own care at some point, and I want to ease him into it. But I've been curious how other families manage that conversation. He's he can be prone to anxiety, not all the time, it just depends on the day, but I don't want to give him fuel for that. So I'm just curious what other people's thoughts are on that.
Hmm. Yeah. Obviously I can't speak from like personal experience with like an own child. But I can speak from, experience from like my own clinical practice and um, you know, speaking with children about their own genetic conditions. And I think a common strategy that a lot of parents use is that, the information doesn't have to be everything all at once. And
Right.
really giving information piecemeal to your child that's age appropriate in a way that they can understand, that's more conversation based and nothing that has to like feel very heavy. Is a really great way, and kind of, starting those conversations and building those foundations to kind of later have those more complex in-depth discussions, even just, explaining DNA and having that conversation, and then the next time going about talking a little bit more in depth about what that might mean and what a genetic, some people have genetic changes and those types of things. There are a lot of really great kids specific resources. And something else too that I'd love to mention is that depending on which center is local to you, but something that we offer at Sick Kids is transition counseling. And it's something that is quite unique, I think, to pediatric centers, where we have a lot of teens who are, 16, 17, 18, and within those years, more independent in their care, exactly like you said. And soon we'll be going into the adult care world, which is also very different than pediatric healthcare setting. And so we, in a transition genetic counseling appointment, meet one-on-one with the teen, and we go through the kind of background genetics information, share with them their genetic testing report. I usually like to give them, provide them with any documents they're missing from their chart, if they don't have any copies of like their letter from genetic counseling when they initially saw us, and their actual physical report, and going through what that means with them, asking them if they have any questions, those types of things as well, and also talking about maybe some more of those kind of like uncomfortable teen conversations that are more age appropriate at that time, like just letting them know there are options for family planning, and they can have preconception genetic counseling if and when they're at that point in their lives and thinking about it. And if they want more information about that today, great, but we don't have to talk about that. It's really like led more so by what information they want, but really to just kind of empower them about their own genetic information and healthcare to help better prepare them for navigating adult care.
Okay.
I'd also be very happy though to hear from other parents how they've discussed retinoblastoma and genetics with their children.
I love that suggestion. If there's anyone else that has a comment on maybe how they've discussed it with their child, I know it was very much piecemealed together for me in my life. There have been different times when it's come back up, like the teenage years and that preconception conversation. I brought my partner to Sick Kids to say, you need to understand this the way I understand it, and you need to know the risks the same way that I do. And the options were presented to me. We also have some resources on our website, as you mentioned, some of the great resources that are out there. And I do think that there are some books and some maybe some dialogue that could be helpful. So I'll again just put into the chat the link to our website in terms of the For Kids content. There's an extensive list out there, and we only have a few things on our site, but we're happy to add more if anyone has any specific suggestions. So I do see that Harel has his hand up. Maybe we have some suggestions.
Hi everyone. My child is only 4 years old, And we did not learn about this until she was diagnosed at 12 weeks old. So she is a bilateral, and we have her genetic testing report. But my question was, once the child reaches the adult age, do they have a place where they can get this counseling, genetic counseling, and is it still is being done through sick kids, or there are other centers that they have to go to?
Yeah, that's a really great question. So with regards to genetic counselors, we work at all different institutions across Canada and within Ontario as well. So it really depends where you are located. With regards to sick kids specifically, we follow pediatric patients up until the age of 18. But
Mhm.
we have adult genetics programs at adult centers that would be more than happy to see adult patients. So there are multiple adult cancer genetics programs. Additionally, with regards to the preconception counseling piece, that's more so related for genetic counselors who work in prenatal genetics clinics.
Mhm.
So there's all different types of genetic counselors. So I specifically work in cancer genetics. Prenatal genetic counselors are actually the genetic counselors who see patients and inform them specifically about those testing options that might be available to them either before pregnancy, during a pregnancy, or even right after a pregnancy. And so um, depending on, what stage your child's at in their life and what kind of the reason is for the appointment, the referral might vary to which kind of genetic counselor they would want to see. But
Mhm.
definitely there are resources available and referrals can be made by family doctors. And so you can reach out to your family doctor. If you don't have a family doctor, a doctor at a walk-in clinic can also make a referral for genetic counseling as well.
Okay. And once the child reaches the teenage stage, like after age 13 to 15, up until age 18, I think they will sort of start to understand this better, and they would also have more curiosity. So during those childhood age, before the age of 18, is there any different counselings being done at the sick kids while they are still visiting that?
For sure, yeah. We're always happy to see patients for a follow-up genetic counseling appointment. We
Mhm.
appreciate that, you know, a 1 hour appointment with a genetic counselor is, I will say, never enough. There's always a lot to talk about. And
Mhm.
also, too, I can appreciate that when we see families, usually it's at a point in their lives when they're going through a lot. There's a lot on their minds, and sometimes all of that information's not absorbed. And really, sometimes
Yeah.
at the end of the appointment, my goal is just making sure that like the three main points are taken home. And really, because children with retinoblastoma, hereditary retinoblastoma, are followed for so long, there's always the opportunity to meet with families again to go over information. And so, yeah, if your child's currently followed at Sick Kids and will be in their teenage years, their ophthalmology team at Sick Kids or the like
Mhm.
retinoblastoma team can refer them for genetic counseling for sure.
Okay. Yeah, because I can relate to that. Like as soon as we found out, we went for a surgery within a week, and then after that, like we got the genetic results after a month. But we did the counseling for that like 1 hour, but it was a period where our mind was not very able to adapt to the situation, or not able to understand what's going on. So definitely having that another meeting would be really helpful.
Yeah, for sure. Yeah, and you can just express that to whichever
Yeah.
physician, and they can make that referral. We get all the referrals to our team, and we go through and triage them. And so, if it's just mentioned, specifically that the patient would like follow-up genetic counseling for like education about their own condition, we would definitely see them for that.
Okay. Thank you.
No problem.
Those are great questions. I appreciate those follow-up questions too, because I think it's very important for us to know how to get that referral. So I appreciate that you've mentioned the different venues, because it's not always so easy to find you guys and to know how to access you. So I think that's important information. I see Sarah, you have your hand up. You have a question for us.
Yeah, first of all, thank you so much, everyone, for setting this up. And thank you, Tristan, for sharing all of your knowledge. It was very helpful and informative. And so my question relates sort of specifically to, I had my genetic testing done in 2006. And so I know that's obviously 18 years ago. And at the time, like I just have a report that my mom gave me. It's like a sheet of paper that says that I'm most likely to have a non-germline somatic case, not inherited, but they could not rule out that any subset of my cells carry the identified mutation at a low level, and that my future children may have a low risk of inheriting the small set not identified by testing blood, and that the blood from these future children should be checked at or before birth. So I guess my first question is, have there been differences in any of this information, and should I get my blood work updated since it was 18 years ago? But just kind of hearing your take.
Yeah, so I mean, without looking at your report and knowing exactly specifically what was done, I don't want you to take like any like specific medical advice. But it sounds to me what you're describing is something called mosaicism. And so I actually have a slide on this. I had it hidden from my regular presentation, but I was maybe anticipating someone would ask a question about it. So I prepped something in advance, which is super great. I'm glad I get to show it. So I'm just going to pull up my slides again here to try and help explain this concept.
I'm sure you're not alone in this question, Sarah, because this is a concept that we get asked often as well.
Super super common question we see. Okay. And I just have to put it into slideshow. Okay, perfect. Can everyone see that okay? Perfect. So what Sarah was alluding to on her genetic testing report is that so the genetic testing that you had looked at the DNA of your tumor or the retinoblastoma, which is our somatic DNA, and then your germline DNA. Usually this is a blood sample, and this is the sample that we use to kind of represent what the DNA would be in all of your cells. And that's because when we start out as one single cell, our blood differentiates really early on. And so it's quite similar to that similar cell we started out with as. And so mosaicism refers to within one single group of cells, some cells have a genetic change. And so, for example, we can say that on this slide, it's saying missing piece of a chromosome, but we'll say, for example, the green cells have a harmful RB1 variant. Now, when we do genetic testing and we get a negative germline result, that's reassuring that likely it's a sporadic somatic case, but we're only testing one small sample of one person's blood. And so we can't say for certain that that person might be a mosaic. And maybe we only tested all of their blue cells and we got a negative result when really this person is a combination of blue and green cells. And they have some cells with a harmful RB1 change and some cells without. And so it's possible that their egg cells have mosaicism, and potentially some of your eggs have the RB1 change, even though it's negative in your blood. And there's a chance that, very, very low chance, that your child could have hereditary RB and have inherited that DNA change potentially. Now, whether there is any specific updated testing for you is a really great question, and I unfortunately can't comment on that specifically without looking at your report and like the specific genetic tests done. But if you do have questions about that, definitely, again, you can ask your family doctor for a re-referral to whichever genetic counseling center you were seen at before, or whichever one is local to you currently. and they can review your report and see if there's any updated testing for you to determine if they're able to detect any levels of mosaicism with any more or less detail. Typically, though, it's kind of a standard on genetic testing reports for RB that when we do test tumor and blood together and we only get results in the tumor and not in the blood, that we just always put on there that this is just a limitation of only testing a subset of cells of someone, that we just can't guarantee. And it's possible that some of their cells have the change and potentially it could be. Does that make sense and answer your question? It's a very complex topic.
Yeah, so just to clarify, like if the somatic result or for all somatic results, like they would have this note on it as well, that it's not
Yeah.
guaranteed.
Usually most of them do, yeah.
Okay. And then a follow-up question that I had was related to the point about blood from the children. So if you do per se inherit or give the gene to a child, are you able to identify it right away, or is it something that like will arise and only be able to be tested like once the tumors start to grow and once it's fully developed?
Great question. And so just for everybody here, I can briefly kind of go over the options for testing. And also this is currently just like options at this time. You know, genetics and what we know and our technology is always changing. And so who's to say that, even in 3 years' time, there's not new tests available. But currently, we have what's called pre-implantation genetic testing. So this is testing that can be done before a pregnancy. And so how this works is essentially an IVF procedure where the female partner undergoes a hormone medication therapy to basically overstimulate the production of eggs, egg retrieval process. They combine the eggs and the sperm together to create embryos, and they let the embryos grow for a few days. And then once they get to a certain size, they take a few cells. They actually take cells from the outer ring of cells that become the umbilical cord and the placenta, not the inner cells that go on to become the fetus. And then they're looking for the DNA change in those cells that they're testing. Now, with pre-implantation genetic testing, embryos that test positive wouldn't be used for implantation in in vitro fertilization. And then embryos that test negative can be used for a pregnancy. And for example, if there's like many embryos that are negative, they can like transfer one and freeze the rest for future pregnancies potentially. So that's one option. And I should have said this before, but not every option and decision with regards to family planning is unique. There's no right or wrong choice. It's really dependent on your own lived experience, your own feelings about the procedures. Within testing within pregnancy, they are invasive procedures and there are risks associated. And so it's really kind of weighing the pros and cons of testing, and everybody's different, and what they feel comfortable with doing is different as well. And so I want to stress that genetic counselors' jobs are not to make anybody have any type of procedure or testing. Our job is really to help answer your questions and give you the information about all the options that are available to you so that you can make the best choice for yourself and your family. So that's my spiel. There's two options for testing within a pregnancy. These are invasive procedures, as I mentioned. The first one's called chorionic villus sampling, which can be done at around 13 weeks of pregnancy. And this is where they test a sample of the placenta, and then they'd look for the RB1 DNA change in that sample. As I mentioned, we all start out as one cell, and as we grow and divide into an embryo, the outer cells become the placenta and umbilical cord, and the inner cells go on to become the fetus. And so with the CVS, we're testing those outer cells that go on to become the placenta. The other procedure is called amniocentesis, and this is a procedure where a needle is inserted either through the abdomen into the uterus to take a sample of amniotic fluid. Um, and you might wonder why we're taking amniotic fluid to do genetic testing, and that is because the amniotic fluid actually has some of the baby's skin cells that they've naturally been shedding as they're growing and developing. And so we're actually doing genetic testing on those babies' dead skin cells that are floating around in the amniotic fluid. And removing that fluid doesn't actually cause harm to baby because by that point in pregnancy, most of the amniotic fluid is actually made up of baby's pee, and it's actually like regenerated within 24 hours. So some fun facts there. But with both of these procedures, they are invasive and there is a risk of miscarriage. And so that's an important factor that weighs into decision making. And then lastly, there's testing that can be done right after pregnancy. And I think specifically for individuals who have those questions about mosaicism, this might be kind of more the option. Thinking about pre-implantation genetic testing, as well as testing within a pregnancy through one of those invasive procedures is more for individuals who have a known pathogenic variant and are at that 50% risk of passing it down to a child. But we can do something after baby's born called cord blood testing, where right away we take a sample of blood from the umbilical cord of the baby so that we actually avoid having to put baby through a needle and blood draw. And we can do genetic testing from the cord blood to look for those specific somatic RB1 variants. So it's what we call a targeted test. And we're looking in the umbilical cord blood DNA to see, yes, are these DNA changes there, or no, are they not?
Thank you. That's helpful.
That was a great explanation. I appreciate that. I remember having those conversations and going through those options myself. And it was also explained to me that if I wanted to discuss early delivery, so like trying to maybe induce a couple of weeks early if there were signs or if I did have concerns, so that we could start treatment right away. Being a unilateral somatic, and I knew that I really had a low chance. I carried both my kids to term and then brought them right down to sick kids before they were 2 weeks old, had their eyes examined and the little blood test to determine quickly that they weren't carriers and put our nerves at rest. But I really appreciate all of the, explanation about the options. That's very much what was explained to me as a parent to be. So thank you so much for giving us that information as well. Lindsay, you have your hand up for a question.
Hi, so I am from the United States, so I know that this might be a little bit different, but I'm hoping you guys can maybe give me a little insight in, at least in Canada, and what is, I don't know, just normal, so to speak. But I am a bilateral retinoblastoma survivor. Nobody in my family has ever had it that we know of. And there's another gal that is 6 weeks older than me that lived a mile away from me that we had never met until we met, well, our parents met in the hospital when we were getting treated. That also, same thing, bilateral retinoblastoma, never had cancer in their family. So it's like, a mile away from each other, never had it. Interesting. But so I guess my question though is like, I am 40. I have paperwork that said I was like referred for genetic testing like when I was younger, from what I can tell. I have a big long paper that talks about, lots of details of like how big my head was and what chromosomes, and I turned it into the genetic counselor that I saw, and so it doesn't sound like it was ever done. But from what I've been told, it doesn't sound like a lot has changed in 40 years. But I guess my question is like, so if I don't want to, if I'm like never going to have a child of my own, I have been told that there's no reason to do genetic testing because it's just assumed that I am a carrier because I had bilateral. but that's kind of been a little bit of a depends on who you ask kind of situation. But it becomes important to me because in the United States, there's like, I think they told me 2 or 3 places that you can do like labs that will run genetic testing, like in the whole entire United States. So like my insurance won't pay for it because it's halfway across the country and they're saying it's not an emergency, whatever. So I would love to have the information, but is it recommended, I guess,
Yeah,
outside of just when you're gonna, other than having like having a baby.
yeah. And I mean, coming back to recommending genetic testing, I think again, it's really someone's decision, and it all comes back to
Or
how
what information can you get out of it, I guess.
and
Like,
and I mean, I guess to answer your question with a question, like who's to say how valuable or not valuable that information is to somebody? I mean, in Canada, we're a little bit different because we have regulations and like eligibility criteria on who can have genetic counseling and genetic testing. And I don't have an extensive knowledge on, uh, unfortunately, on how that system works in the States. From my understanding, there's not necessarily set criteria, and additionally, there is expenses that can be.
yeah, I mean, it's about $1,000 out of
Yeah.
pocket if the insurance doesn't pay for it at all. So
So, um, I guess coming back to the recommendation piece, it really depends on how, if you feel that information would be valuable to you. I think no one can say to you whether or not you should or should not have genetic testing. I've seen a patient before who has a different condition, and he had genetic testing a really, really, really long time ago before they were even able to say what specific the conditions caused by missing a piece of genetic information. But they couldn't say like where exactly he was missing pieces. They just knew a piece was missing. And he came back to clinic for repeat testing because he was very involved in the support community, and he felt left out because people were making friends based off of having similar deletions, and he didn't have that information. And so, and hearing his story really opened up my eyes, and exactly, like who's to say that's not valuable? And so I think whether or not it's recommended doesn't
I'm just thinking from the like medical knowledge. I mean, for me, yes, would it be nice to know, do I for sure 100% do I have the gene, the carrier or not? Yes, that would be nice to know, but
from a medical perspective, if you're diagnosed with a bilateral retinoblastoma, we would say that, and we counsel in our clinic, that it's a 100% chance it's hereditary.
okay.
Even in
Because that's what I've heard. Some people have said it's 95%. Some people, I've like, I guess for me, there's a difference between saying, oh, it's assumed or it's most likely versus it is 100%.
I mean,
So that's what I was curious. It sounds like you guys say 100% too.
yeah, 100% sure. Like, and I mean, this is where it also becomes complex with genetics because we don't know what we don't know. So it also becomes difficult in that sense. But something to look into too that I want to suggest is, depending on the labs that offer this testing, I'm not sure specifically if there's funding for RB, but some labs have specific programs to help fund genetic testing for individuals. So that's always something to look into as well. If insurance doesn't cover genetic testing, there might be other avenues to get funding from the actual specific lab.
Yeah, and I know I looked into that a little bit. What I found is it was based on income. So like I could get, it wouldn't be free, but I could get a discount possibly. Because I did go and I mean, my insurance would pay for me to do the genetic counseling, but not the genetic testing, which doesn't make sense to me, other than the genetic testing has to be done outside of the state of Nebraska where I live because we don't have a lab. Like I said, there's only like 3 in the United States, but sounds like though, if you're saying from the medical perspective, if it's 100%, there's basically no chance that if I did genetic testing that it would come back as I'm not a carrier.
Well, okay.
That's kind
There,
of what I was trying to understand.
yeah, I mean, so that's what I'm trying to get at, that individuals who are diagnosed with bilateral retinoblastoma. So yes, we'll send for genetic testing. We counsel that it's hereditary. We send for genetic testing, but sometimes we still get negative results. And what I'm trying to allude to in that is that maybe our testing isn't perfect. There's lots of letters in the RB1 gene, and I didn't go into too much detail, but there's also many different parts of the gene, and the gene is
Okay.
processed in a way, and pieces are removed and cut out. And so maybe the way that we test and our current technology, or the technology that exists at the time of someone's testing, is not able to detect that variant. It doesn't necessarily mean that it's not hereditary. And so having a diagnosis of bilateral retinoblastoma with a negative genetic test result doesn't mean it's not hereditary. We can't rule that out with a negative test result, unfortunately.
Okay. And if it's hereditary, if you're assuming it's hereditary as a bilateral retinoblastoma survivor, then as far as risk factors for secondary cancers, that would be assumed, that's what I'm looking at it is, like I said, if I don't have a child of my own, well, they're saying if it is hereditary, then it's more likely to get secondary cancers than if I had RB and it was not hereditary.
Yes,
Is how I understood it. Does that sound that way, you guys?
correct. And
Would
then
say too. Okay.
something else too to think about implications. So again, coming back to the fact that we share genetic information with our family. So I know, Lindsay, you shared, maybe you're not in a place, or ever will be in a place where you're considering having a child. But something to consider, is if you have hereditary RB, which is most likely the case, considering you have a bilateral diagnosis, it's most likely that DNA change would be new in you, but there is a chance that it could be passed down from a parent. And so if you have siblings,
Yeah.
knowing about that information might be important for them and for their future family planning.
Right.
And so it again, this is where it sometimes gets complex with genetic counseling, because again, it also comes back to the individual we're seeing in clinic. And sometimes that individual doesn't want to have genetic testing, and that is up to you. But it's also, I guess, important to let your family know that
Yeah.
there's potential risk for them too. And
Right.
yeah, if you do have genetic testing and are determined to have a variant, then your family members would be eligible for testing to determine if they have it as well.
Okay. And then genetic testing, they gave me the option, if I choose to do it, to do like the spit test versus the blood test. Do you guys feel there's one that's better or more accurate than the other, or does it really not matter? Or is that totally different in Canada?
Yeah, really great question. And I mean, I'm only speaking from my own experience and what I know. I mean, spit kits are really great because they reduce some barriers to sample collection. And again, I think, at the end of the day, if someone has like a severe phobia of needles or something like that, and that's the only way we can get a sample, that's really great. And that's awesome. We should do that. But blood samples tend to be better for genetic testing. They tend to be accurate. With the spit kits, there can be things that interfere with the DNA sample. So for example, if there's specific rules. So like you can't eat or drink anything half hour before,
Right.
that can interfere with it. We've even seen even wearing lipstick sometimes and doing the spit kit can sometimes impact the DNA. To answer your question, like, yes, if you don't have a personal preference, getting blood would probably be best. But if you do want, if you have a personal preference and are feeling more comfortable with one over the other, there is, again, like no right or wrong choice.
Yeah, I'm just like, if I'm going to spend the money, I'd rather do what's the most accurate. And the other piece of it for me personally, I guess, is just my sister is 2 years older than me. So obviously when she was born, retinoblastoma, I don't think my parents even knew what it was or nothing. It wasn't even on the radar. But she's had 3 children and nobody has, knock on wood, has ever had any issues, and they're 9, 7, and 5. So the likelihood now is probably very slim.
Yeah.
So that's the other piece that's just really interesting to me is like, I have this hereditary cancer, but nobody in my history has it. My sister doesn't have it. Her kids don't have it. But why the do I have it?
Yeah, and it
Or
comes
had?
back to, like, probably the most likely scenario or story is that, in that single egg or sperm that made you, there was just that random event that happened that created that DNA change, and you're uniquely you. And the eggs and sperm that created your siblings didn't have that.
Yeah. But yet I'm still have the hereditary is the interesting part to me. So
Yes, because
I
if
appreciate
you have
you.
children, there's a 50% chance you could pass it on to them.
Yeah. And I've also heard between 25 and 50 for my sister's kids though, too. And I don't know what what your knowledge is of the most accurate, up-to-date number, but
Sorry,
like my sister's kids, is it 50% for her too? I used to be told always 25%, and then more recently I've been told, well, your sister has the same chance of your kids as passing it along.
if she has it. So we can't really speak to risks without knowing for sure whether or not there's variant in the family. So, if we tested you and you tested positive for a germline variant, and without testing your parents, it could be that it's new in you, or if it was inherited from one of your parents, then there's a 50% chance your sister also has it.
Okay. Can you inherit it from your parents if your parents never had RB though?
So yes, this is
Okay.
kind of gets even more complex. In genetics, we see with a lot of conditions, actually, something, the technical term for it is called reduced penetrance. And so what this means is that not everybody who has a harmful genetic change will go on to develop a retinoblastoma. That's why we say that having one of these pathogenic RB1 variants increases someone's risk to develop hereditary retinoblastoma. Most individuals do develop them, but not all. And so we can see parents who have one of these harmful genetic spelling changes, and they pass it on to their children, but they themselves have no history of retinoblastoma. And sometimes we can actually see too, no family history of retinoblastoma, but maybe the parent has what we call a retinoma. This is a benign tumor of the eye that can be a precursor to retinoblastoma and is a risk factor for hereditary RB as well. And so sometimes, again, when we see families coming to clinic, that's why it's so important to get a family history, and that really helps us with the risk assessment. And I see another hand up.
Thank you for your information.
Yeah, that was a great question. And I think that our other hand up is actually from a family who has that exact scenario.
Yes.
Go ahead, Mark.
Yeah, two things. I originally put my hand up to say that the genetic testing, we often think of that as being a benefit for family planning and kind of long term, but there are also short term benefits because in our family, my mom had it, and then she had 4 children, myself, a sister, and 2 brothers. Genetic testing was done only when my daughter, my only child, she was on the call, she's gone now. She was diagnosed with it. Then they found the records of my mom from 1940 at the hospital, determined it was hereditary. Of the 4 siblings with that genetic testing, 3 of us have the mutation. None of us got retinoblastoma. But since, and I'll stick to my first point. When we found out that what the mutation was, my sibs were tested, and that took a little time. This is 1996, so it was a while ago. Took a little longer. In the meantime, any of the children, the nieces and nephews, did have examinations under anesthetic, but as soon as we got the results of that genetic testing, my sister, who had 2 boys, found out she was the only one that didn't have the mutation, so her boys didn't have to go through those traumatic, for the little ones, traumatic EUAs. So, I mean, just in the short term, for them, it was a very real benefit. And then to your point about can someone who doesn't have it pass it on? Yes. Not only did I pass it on, unfortunately, to Jen, but I have had, as of last month, 3 cancers since. No retinoblastoma, but Brian doesn't know about the last one. Leiomyosarcoma, bladder cancer, and thyroid. Thyroid, I'm told, was not one of the great risks. That's why I asked about a list of risks. It's never mentioned, so I might just have got the bad lottery on that one. But yes, you can pass it on. It's not a definite, but it's good to know to look out for things. And as we tell the just like Jen has children who are growing and becoming independent adults, they need to know to pay attention to everything and go and be tested if things don't clear up, right? So it's good to have the most up-to-date information for them.
So it sounds like if I got tested for genetics, then, I mean, yes, it would help, like my nieces, my nephew, down the road. But possibly for secondary cancers for myself, that's what I was trying to figure out, if it would give me more information as far as the risk factor, how high of a risk factor. Like, I had the retinoblastoma, but I also had radiation, which also is a risk factor for more cancer. So, I had skin cancer a couple years ago too.
Another reason why it's good to know and to have, because you have to prove yourself sometimes to some doctors, to have it on paper is to hand it to them, and so that informs their decisions about how they're going to move forward with treatment. So it's all, I mean, more information is always good.
And something else too, I want to touch on about, having a hereditary cancer predisposition syndrome and developing multiple primary cancers. We know too with cancer syndromes that there is an increased risk for certain types of cancers. And sometimes individuals who have hereditary cancer syndromes still develop sporadic cancers as well.
Yep.
And so that's kind of alluding to the importance of testing the tumor DNA and testing the DNA of the blood to kind of understand the genetics of both. And actually, the cancer research project I work on, that's kind of our main goal, is to sequence both tumors and cancers for children who have very diagnosed and to treat cancers, to kind of better understand and to kind of provide a more personalized approach. But we see that a lot where even we do genetic testing for children who have pediatric cancers, and we don't find a genetic test result that explains the cancer they have currently, but we find a cancer predisposition syndrome diagnosis for an adult cancer onset predisposition syndrome, for example, like a hereditary breast or ovarian cancer, where we know the risks maybe don't start until adulthood. And so maybe doesn't explain the reason why they develop brain cancer at age 10, but now we know that when they're in their 20s, they will have enhanced breast cancer screening because they're at an increased risk for that. So cancer itself is very, very complex. And again, someone can have, an increased risk to develop certain types of cancers, but then develop other types of cancers that are sporadic. And unfortunately, cancer in general is quite common in the general population. And thyroid cancer, breast cancer, prostate cancer, colon cancer are all very, very common as well, unfortunately.
Sorry, did you say thyroid?
Yes, thyroid.
Okay, my doctor couldn't find any connection between them.
No, sorry, not between retinoblasts. Sorry.
Oh, okay.
Comment. Sorry.
Thank you.
They're common in the general population.
Thank you.
Yeah, not common.
Clarification.
Retinoblastoma. Yes, sorry.
Thanks.
Thank you for making me make that clarification. That's a very important one.
Is breast cancer one of them, tied to retinoblastoma?
So when we think of retinoblastoma, the main increased cancer risk that we're really concerned about is something called pineoblastoma. This is a specific cancer of something called the pineal gland. The reason why this can also be affected with in hereditary RB is because the cells that make up this gland are also very similar to the cells of the retina. And those are the most known cancer risks. I believe the document I shared might have talked about other ones. And then we always see, you know, in the scientific literature, case reports of things. But in cancer genetics, really, when we think about cancer screening, um, we screening protocols, unfortunately, are usually only put in place when we are able to have sufficient evidence to establish the links and associations between, you know, genetic variant and the risk of cancer, and the risk has to be sufficient to kind of warrant the screening, especially as Marg alluded to, when the screening for some of these cancer predisposition syndromes can be quite intense and you know, can be a lot for an individual to go through physically and emotionally as well.
Great points. Really, really good conversation. Thank you so much for your knowledge. I don't know how we would be able to capture these specific nuances of our disease without someone like yourself taking the time to explain these things and answer very specific individualized questions. It is getting to about 8:25. Does anyone else have a question that's, you know, burning before we say goodnight? Sarah, yeah, go ahead.
I just had a quick question. When you spoke to when you have it in both eyes and then the test, even if the testing reports that it's not hereditary, you assume it is, that led me to wonder what the rate of accuracy is for the test initially for someone who has it in one eye, of it being accurate as to it's hereditary or not.
Sorry, just to clarify, like when I think you're asking, like, when someone who has unilateral RB has
Mhm.
genetic testing and they get their report back, like, how accurate is that result?
Correct.
Okay. Yeah, so really it's going to depend on what the specific genetic testing like method used was. So there's different types of genetic technologies and genetic sequencing technologies. Some are more accurate than others. It's the way sequencing is done is very complex. Sarah, if you have your genetic report handy to you, there's likely after the information about your report, and probably in very small print at the end, going to be some information about the technology that was used in the testing. In that specific area, you can likely find information about any limitations of the genetic testing, and as well as what we call the sensitivity and the specificity of the test. Typically, most labs include that in their genetic testing reports. Unfortunately, I'm not able to answer the question specifically, as it depends on kind of where you've had the testing done. But what we know is that specifically for hereditary retinoblastoma, this is like the only gene as well that we know is related, which makes it also a little bit more accurate for testing results and easier to test for, unlike other syndromes where there can be many different genes that can cause an increased risk. For example, like for breast cancer, sometimes when we offer panels, there can be maybe over 30 genes that we're testing somebody for and doing sequencing for, and so testing might be less accurate in that sense. And so it's really up to the specific testing you had done. I'm sorry, I can't answer with specifics, but usually it is quite accurate, specifically if they've done a type of sequencing that's what we say has like lots of coverage, meaning that they sequenced that area many, many, many times and did many separate kind of individual reads of that area of the DNA, and every time they're seeing the same letter.
Thank you.
And I also, sorry, just wanted to say too about the secondary cancer risks. Also forgot to mention, pineoblastoma is one of the ones we're more concerned about as well in childhood. specifically thinking for adults and adulthood cancer risks, because I feel like maybe the question was more geared towards that. We can see increased risks for certain cancers like melanoma, sarcomas, and different types of like CNS cancers. But again, the kind of specific risks can really range. Depending on what information you're looking at. And so a lot of this data comes from research of individuals who have hereditary retinoblastoma, and we're following them for a certain amount of time, and we're seeing what secondary cancers they develop. And so depending maybe on the study and the research and the reference you're looking at, those numbers might shift a little bit.
Great answer. Thank you. I see, Harel, you have a question?
Yeah, sorry, I just have one follow-up question to that. For those who are at a higher risk of those secondary cancers at adulthood, in Canada, does our health system allow for those who are at higher risk go for further testing more easily compared to the common people who are not at those risks? Like, or is there the barriers that they need to also climb and figure out the path and the treatment?
I'm so sorry, Harel. Can you just repeat the question for me?
No, so what I'm trying to understand is, like, if my child, when my child is an adult, because she is bilateral, she knows that she is at a higher risk. If she has any issues, then people with a higher risk, does our Canadian health system allow them to go for further testing more easily compared to the other who are not at that risk? And do they have access to those facilities more easily?
Yeah, so that's a really good question. And I don't know if I can really speak to that specifically. I mean, it would be my hope that yes, if we know someone's at high risk for something, then we are taking that very seriously in the medical system, and using that information to help that individual. But I will also like allude to the fact that our medical system is not perfect.
Yeah.
And so really I always like to tell patients and families that, if they're noticing something, I see families of children with leukemia, and sometimes the signs for leukemia can be something like recurrent fever, which can be super common in children. And if we know that someone's at an increased risk for leukemia, obviously every time that child has a fever, mom or dad might kind of freak out, which is valid. And I always tell parents, it to listen to their gut feelings. You know your child best, and if you think something is wrong, then definitely take them in to get it looked at. Unfortunately, there's not any screening recommendations made for adults for those cancer risks. And so it unfortunately just falls a lot of the times back on the patient to be diligent with their own healthcare, and knowing themselves and their bodies, and keeping a lookout for any signs of anything that's not typical, and then kind of initiating that referral process with their family doctor to get that looked at and investigated further, and whether that requires further follow-up with a specialist or imaging, etc.
Okay, yeah.
That
Thank
is
you.
exactly kind of the experience, but I would add to that a little bit that the United States are a little bit further ahead in this area than us.
Yeah, I was about to mention that.
Yeah, the survivorship programs in Canada are not as established, but there are graduated programs. For example, at Princess Margaret, some of the adult survivors attend their survivorship program, and they are monitored for secondary cancers. But as Mark mentioned in her earlier comment, that sometimes the genetic testing and having that letter or that piece of information can help you as an advocate, which is something that we all learn to become for ourselves and for the child. Myself being the RB patient, I am my own advocate. And I've had to learn how to explain to other medical professionals why I need certain testing, why I need more surveillance, why I might be at a higher risk. And sometimes we have to be the expert in pushing forward for some of these concerns to be addressed. So it's not a straightforward answer, but yes, you would have hopefully more access to treatment and to screening methods and to clinics who can help to surveil some of these concerns. But at the end of the day, as Tristan said, yourself and your child know your needs best, and you will have to be the advocate to push for some of your concerns. And hopefully in the long run, Canada can catch up a little with some of our Southern examples, because in the US, they do a really good job at their long-term survivorship programs, where they do provide guidelines on screening and watching for other types of cancers, and they have a little bit more support established for those adult survivors. So Michelle, you can allude a little more, because I know that you're
Yeah.
American.
So I guess for context, I've lived like on both sides of things now. I grew up in the US before moving to Toronto. So I've seen both, in New York where I originally had my treatment and had like I've continued to had follow-up there as well, but also have like slowly started transitioning things here. The long-term follow-up situation is very different. Also, just what the surveillance has looked like has also been very different. There was like a period of time in the US where like what based on your age, whatever like second cancer was most common at the time. So for me, that was like in high school, it was bone cancer. Was you would get scanned for it basically. So that meant, every year I would get a 3.5 hour MRI of all of my bones and all of that. And eventually, I guess, the like scientific literature came out that, you're not necessarily catching things much earlier in that way. So, especially to like justify, having patients do all of that, that meant like traveling several hours and like, sometimes you have to be sedated if it's like several hours in there, right? All for, what is ultimately like not a significant like chance to catch anything but earlier. So there like some things have worked, some things have not. There are things that do happen in the US for just that are a little bit more thorough than there are here, to be honest. For instance, like cell-free DNA testing, which I don't know if Tristan can get into a little bit, is something that just recently kind of transitioned from like the research phase to like a clinical implementation phase, in some clinics in the US. And that's still something that we're seeing for in Canada, or seeing for other hereditary cancer syndromes mostly, and less so in RB in my experience. And that's both, working in research and also being a survivor myself. But the big benefit, at least like, in my experience with the Ontario follow-up clinic, is having that central location that knows your situation and then knows like that is a central place for which you can get referrals for scans or anything if something does come up. So like they do have your back in that sense. It's just, the process by which like the passive surveillance takes place is I think the biggest difference. But if you have an active concern, then like they're definitely there for you.
This is all very good information. Thank you, everyone.
Thanks, Michelle. And I just want to say I saw your direct message question, and
Yeah, I was worried of it being a bit in the weeds of cell-free DNA and all that kind of thing.
I can't think of anything off the top of my head right now, but I work within the RI at Sick Kids, so I will, if you don't mind, like look into it. And can I reach out to you? Because I know you work at Sick Kids as well through like our institution email.
Yeah, go for it.
Okay, perfect. Thanks.
Thanks.
All right, thank you so much for all of those rich questions. Some really good information. And again, I really appreciate everyone who has made some time tonight to join us. Such an important opportunity, and there were a lot of great comments, a lot of great discussions had, as well as in the chat. We had a couple of people just put their own kind of reaches. I see Isaac's put in something about wanting to connect with other families who have had maybe similar situations with retinal detachment. And he's put his information, phone number in the chat as well. And I know there are some other parents on the chat who might be looking for support also. And you've come to the right place. So thank you for joining us. And we really appreciate that you've made some time to be here. Lynn's just said, thank you. This is very productive, found it very helpful at this stage in my life. And I know that she is the peer support president from Lebanon. We work with her here and there, and she's doing some amazing work within her country to provide support. And we also heard from Marg, who just said, thank you for the opportunity. Clarification is helpful, and knowing that you're not alone is some of the best help out there. So just want you all to know that you're not alone, and we are here to support each other. And I think it was recently at an RB event that this was not a club that any of us would have chosen to be a part of, but we are, and we're here as a community, and we appreciate that that we have each other and that we can share stories and be there for each other. So if there's anyone that would like to ask further questions, please feel free to email them to the Canadian Retinoblastoma Society or to Tristan directly. We have put her email in the chat. And if